Good morning, everyone. My name is Carol Timmings, and I am RNAO's proud president. It is my pleasure to welcome members of the media and guests here today. The Registered Nurses Association of Ontario, also known as RNAO, is the professional association that represents registered nurses, nurse practitioners, and nursing students in Ontario. Our mission is to advocate for healthy public policy, promote excellence in nursing practice, help shape and strengthen the health system, and influence decisions that affect nurses and the public we serve. Today marks the beginning of Nursing Week, so allow me to take a moment and applaud all nurses and nursing students for their immense contributions to the health of Ontarians. Nursing Week is a time to celebrate what we have achieved and a time to reflect on the work still ahead to make our health system stronger. RNAO's theme for this year's Nursing Week is Values, Evidence, and Courage. It's a fitting theme because these are the words that guide the work we do and the issues and recommendations we will present to you today. I'm pleased to be joined by RNAO Chief Executive Officer Doris Greenspan and Nursing Research Associate Zainab Loulat. Today we are launching the largest ever publicly available body of evidence about registered nurses. It is fitting we do so at the Ontario Legislature because it has significant implications for our political leaders and civil servants as they make decisions that affect the health system and the lives of Ontarians. Thanks to the outstanding work of the research team, 7 decades of health research were reviewed and compiled into a comprehensive database of evidence on the impact of RNs. The product of these efforts in a research database called 70 Years of RN Effectiveness, which anyone can access. Of the 626 peer-reviewed research studies in the database, more than 95% indicate the positive impact RNs have on patients, health organizations, and the financial outcomes of the health system. Overwhelmingly, this evidence shows that RN care leads to better health outcomes, including saving lives, reducing rates of infection, improving patient satisfaction, and reducing costs in healthcare. Now, I'd like to introduce Zainab Loulat, the lead research associate on the team, who will tell us more about the scoping review used to create this database on RN effectiveness and some of its findings.
Thank you. Hello, my name is Zainab Loulat, and I'm a nursing research associate with the RNAO. I'm now going to provide an overview of the methodology we used to build the database on 70 years of RN effectiveness. In essence, we conducted a scoping review to identify and compile evidence into a free, publicly available electronic database on the effectiveness of RNs in 3 key areas: clinical and patient outcomes, organizational and nurse outcomes, and financial outcomes. We started our scoping review by developing research questions to guide the focus of the database. Our research questions were: what is the effectiveness of RNs in improving clinical and patient outcomes, organizational and nurse outcomes, and financial outcomes when compared to other health workers, including other types of nurses and unregulated care providers, or the absence of nursing care? It was important to have a comparator in our research questions, as this was the only way to truly determine the effectiveness of RN care or staffing. We had pre-identified criteria for the types of literature that would be included within the database. We included peer-reviewed literature focused on RN care or staffing published in English. There were no restrictions placed in terms of healthcare discipline, setting, sector, or patient population. International literature of any research study design was also eligible for the database. We excluded studies from the database if they were not research studies, focused only minimally on RN care or staffing, did not include a comparator, were not published in English, or were not retrievable electronically. In collaboration with a health sciences librarian, we then conducted literature searches for each of the research questions within 4 electronic databases. We searched the databases for articles published from 1946 to 2016, covering 70 years of research from the inception of the database. The program we used to store and screen our search results is called EndNote, and it is reference management software. For each of the 3 research questions combined, our literature searches yielded over 96,000 records. In order to pinpoint relevant articles, these records were screened electronically for pre-selected keywords within their titles and abstracts. Following this, manual title and abstract screening, as well as full-text reviews, were conducted as needed by 2 independent reviewers. This narrowed the database down to 626 abstracts. The included studies were organized within the database according to the research question or outcome measured in relation to RN effectiveness. Our analysis found that more than 95% of the 626 articles captured in the database demonstrated positive results from RN care. Just 18 studies, or 3%, demonstrated conflicting outcomes, meaning that the study found that RNs were not effective, while 12 studies, or 2%, demonstrated neutral results, meaning that RNs were shown to be neither more nor less effective than the comparator. We also wanted to determine what kind of positive outcomes from RN care were demonstrated in the research studies. High-level outcome analysis was completed by searching for pre-selected keywords using EndNote's advanced search function. The number of relevant articles pertaining to each of the keywords was noted in order to determine the frequency of some of the major positive outcomes present within the database. You can view the results in the RN effectiveness graphs provided in your media kit. The positive outcomes that were present most frequently within the database for clinical and patient outcomes included decreased mortality, increased quality of care and patient satisfaction, decreased ulcers, decreased infections, and decreased length of stay, amongst others. The positive outcomes present most frequently amongst the organizational and nurse outcomes included increased job satisfaction and team functioning, increased organizational safety, decreased turnover, increased retention, and decreased adverse events. Finally, positive financial outcomes included topics such as cost savings, cost effectiveness, and economic or cost benefit. It is important to note that the outcomes I've highlighted here do not represent a comprehensive list of all of the outcomes present within the database. Since this was a scoping review, full-text articles were accessed for only a subset of studies within the database. Therefore, we encourage users to access full-text versions of the articles to guarantee that they are applicable to their own needs. The database is now available online at rnao.ca. It will serve as a resource to support health administrators and policymakers in making evidence-informed decisions regarding health human resources. It will help patients understand who is taking care of them and provide clinicians and researchers with a deeper understanding of staffing and skill mix decisions. The results of this scoping review provide an enhanced perspective on the effectiveness of RNs on outcomes for patients, health organizations, and the health system. The evidence highlighted in this database demonstrates that RN staffing is a critical factor in the provision of safe, high-quality, and cost-effective care. Thanks.
Thank you, Zainab. That's great. Now I would like to discuss what this evidence means for Ontario's health system. As pleased as we are to share this evidence, it is unfortunately not the only evidence we need to show you today. We cannot talk about the outstanding work of RNs without also discussing a trend which is devastating for Ontarians. As you can see, we brought 2 sets of graphics with us today. One shows the evidence that Ms. Lulat presented to you, illustrating the impact that RNs have on patient, organizational, and health system outcomes. The other illustrates a grave trend. It shows how the RN share of the nursing workforce in Ontario is plummeting. The result is that Ontario now has the lowest RN to population ratio in the whole country. Our province needs at least 17,000 more RNs just to catch up with the national average. This is a shameful and unsustainable reality in a province that prides itself on being a healthcare leader. Given all we know about the advantages of RN care, It is shocking that Ontario has allowed its RN workforce to sink as it has. How did we get to this point? Over the past few years, RNAO has repeatedly seen RN jobs cut in favor of less qualified care providers. We even saw one hospital in Hamilton planning to replace RNs with registered practical nurses in its neonatal intensive care unit, where ill and fragile newborn babies are treated. Let me be clear. RPNs and unregulated care providers are valued colleagues, and they have vital roles to play in healthcare, but they simply aren't equipped to care for the most vulnerable in our society. RNs study 4 years and graduate with a baccalaureate degree. RNs are educated to care for people with the most complex needs, and there is no substitute for RN care for patients who need it. Fortunately, this instance of RN replacement in Hamilton was reported in the media, and the outcry from health professionals, RNAO, and members of the public forced the hospital to back down from its dangerous decision. The problem of RN replacement is not limited to just one unit or one hospital. It is part of a broader, short-sighted trend which undermines patient care in the name of cost savings. It is the most misguided strategy I've seen in my 37 years as a nurse, and certainly one that is the most harmful. It happened under Premier Mike Harris, and it's happening again now. It must stop. Replacing RNs will only degrade the healthcare organizations that organizations provide. It will compromise patients' health outcomes, organizational performance, and ultimately it will be worse for the bottom line. Instead, we must heed 70 years of evidence that shows RNs are the key to more cost-effective healthcare while producing the best health outcomes for patients. We are here today to once again say that the government's goal for health system transformation will fail in their delivery if we do not reverse the trends which have chipped away at the role of RNs. Thankfully, RNAO has recommendations to make these much-needed changes, and I will ask RNAO's CEO to share them now.
Thank you very much, Carol, and thank you for all of you for being here today. As mentioned earlier, RNAO was in this very room a year ago during Nursing Week to release our Mind the Safety Gap in Health System Transformation report. The 8 recommendations from the report were and are still today the same. The Ministry of Health must develop a provincial health human resources plan which includes all regulated health professionals working to their full and expanded scope of practice. Until that plan is complete, the Ministry of Health and the LHINs must issue a moratorium on nursing skill mix changes. The LHINs must mandate models of nursing care delivery that advance care continuity and avoid fragmented care. The Ministry of Health must legislate an all-RN nursing workforce in acute care effective within 2 years for tertiary, quaternary, and cancer care centers and within 5 years for large community centers. The LHINs must require that all first home care visits be completed by an RN. The Ministry of Health, LHINs, and health organizations must enable nurse practitioners who are also vital contributors of Ontario's health to practice to their full scope, including prescribing controlled substances, which has recently been implemented by the government, acting as the most responsible provider in all sectors, implementing their legislative authority to admit, treat, transfer, and discharge hospital inpatients, and utilize fully the NP anesthesia role, inclusive of intraoperative care. The Ministry of Health must legislate minimum staffing standards in long-term care homes, including 1 attending NP per 120 residents, 20% RNs, and 25% RPNs, and no more than 55% personal support workers. Last, once CCICs have been developed, the LHINs must relocate the more than 4,200 care coordinators into primary care located in primary care, employed by the LINs, where they can provide health system care, coordination, and navigation. We know that implementing these comprehensive strategies will steer Ontario's health back on track. Yet, a year has passed since we released the Mind the Safety Gap report in this same media studio, and RNs continue to be replaced with less qualified providers. Our question today to Premier Kathleen Wynne, to Minister Eric Hoskins, and to Deputy Minister Bob Bell is, what will it take for you to act? Today, we're delivering to you a review of 70 years of academic research. Study after study makes it clear that RN's care saves lives, make patients healthier, prevents complications, and they're more satisfied, and makes the health system more efficient and more cost-effective. Today, the first day of Nursing Week, RNs all over this province are asking you, Premier, are asking you, Minister Hoskins, and are asking you, Deputy Bell, why have you not stopped RN replacement, either through legislation or through your mandate letters to LINs? And why are you willing to place Ontarians at risk? Premier Wynne, Minister Hoskins, and Deputy Bell, the overwhelming nature of the evidence we are sharing with you and every Ontarian today calls for your urgent action. Patients can't wait. RNAO has long been aware of the wealth of research into RN effectiveness, and of course, as RNs, we know firsthand the impact of our profession. Although the evidence on RN effectiveness is not surprising, seeing all this evidence compiled in one place leaves no doubt that government and employers must rethink health human resources practices. Our Mind the Safety Gap report provides evidence-based recommendations, and now is the time to ask or risk sacrificing the quality of our province's health care. We will open for questions now to anyone. Yes, please.
So I understand your plan, but there's so many other ghosts at the table. Until we rectify and fix those ghosts, how can we possibly? It's not just about nurses that's going to fix the problem in Ontario. So putting nurses in first isn't going to help them. We need to fix the broken system.
Yeah, this is actually not about putting nurses first. This is about conclusive research that the dose of RN care, especially on acute care patients, tertiary, quaternary, also in long-term care facilities. If you see today, there are hardly any RNs and any RPNs for that matter. If you look at home care visits, some home care visits are done, the first one by an RN, others are not. And there is conclusive research on that aspect. So this is about all the pieces of the system. RNAO has long been supportive of health system transformation. But what the government forgot, what Minister Hoskins forgot in the plan of health system transformation, is health human resources, and that's very grave. And 70 years of research is open to the public. We will continue to build it, and we will start to see decreases in health outcomes. There is no doubt about that, because that has happened in the past in other jurisdictions when that is the case. And that's unfortunate. That's why Ontarians cannot wait. Other questions? Yes, please.
Doris, the Ontario Nurses Association has not really seen an increase in the RNs, specifically in hospitals, across the province, but specifically in hospitals where the complexity and acuteness of the patients is increasing. What have you been seeing with the Registered Nurses Association of Ontario?
Absolutely, we concur. Overall, as you can see, there is a plummeting on the RN share, or what we will call RN dose for patient care across all sectors except of public health, actually. All the other sectors, whether it is home care, whether it's public care, whether it's long-term care, whether it's hospital care, has seen a decrease. What we ask government, and we have met with government, and we share also with the opposition parties, both of them, is very minimalist to start with these 8 recommendations. We start for an interprofessional health human resource planning. We are actually making progress on that. RNAO and Denise called the ADM held a forum on that, and the government is moving forward. But meanwhile that the government is moving forward, all the other 7 recommendations have not happened. A moratorium is essential in terms of skill mix changes at this point. If it not, employers continue to do that. And what we are asking is a very minimalist approach. Linda Aslam, the president of ONA, asked the question. And the minimalist approach is, at the very least, in tertiary, quaternary, acute care hospitals, you absolutely must have an all-RN staff. The Deputy Bell agreed with that, so I am not sure why government is not moving with that. And we ask also that cancer care patients in acute care hospitals be also RNs. And again, the deputy agreed with that, so I'm not sure. I'm not sure what are the gamings between the offices of deputy minister, premier, et cetera, and OHA, of course, right? But what is this is a message for OHA now. What is most concerning to us about the way hospitals are being led, and let me put parentheses and exceptions, because we have colleagues from Mount Sinai that is an all-RN, from UHN that is an all-RN, from Sick Kids that is an all-RN, from St. Michael's, which is an all-RN. So it's not everybody, but those that are de-skilling, and there are many across this province, is that the economic argument falls in the face of the evidence, because the economic evidence, as Mr. Lulat just presented, is that in fact the rents are more cost effective, especially with complex patients. So it is a misguided, it's not just even a short-sighted strategy, it's a misguided strategy. So I will send CEOs that are engaging with the CFOs in this skilling patient care, I will send them back to school, quite frankly. Any other questions, please? Absolutely.
Isn't it true that the research involved isn't a recent look at today's Ontario's registered practical nurses?
It actually looks at all the research, absolutely all. It looks at the research up to 2016. And let me remind you that we moved to baccalaureate entry to practice on the RN side 4 years is because we believe that that's the type of care required today, right? So this is conclusive in the US. It has been looked in other countries. It has been looked in Europe, has been looked. So yes, all of it. And if you have different research, or for that matter, anyone, this is an open source for everybody. If anybody finds other research, we will be delighted to receive it. And we will, if it's peer-reviewed research, we will include that by all means. If the lady has a question, if you don't mind first.
Sure. So I guess what I'm going to ask too is, do you believe that privatization is driving the factors of the ratio down? The reason being is the dollar value that's paid to maintain our healthcare system for the private places. There is a profit margin that's automatically carved off the top. And for them to reap those rewards, the money has to come from somewhere. It has to be either staff or lack of care. Do you not think that plays, the government's piece of privatization plays a huge part in your concern?
So let me respond first an overall comment and then specifically to your very important question. I will send them back to school too, because actually RN care is more cost effective. There is studies back to Linda Lee O'Brien Palace years ago that show that when patients in home care are cared by an RN, that they stay less time in the care of the system. So you will save money. But privatization has a very short-sighted way of looking at things, and you absolutely have a point that if you look at St. Elizabeth, every single home care visit is an RN, and if you look at some of the private places, it's not. So, but again, if they looked at the evidence, they should know better too. So you make a very important point. Other questions? I think you had another question.
My question is about nurse leaders at the point of care. Don't you think they are best qualified to make nursing skill mix staffing decisions based on their patients' needs? Why do you think that you or a politician know better than the nurses who actually work with patients?
Because your comment is very important, but ignores Powerbases. The reality is that many of our colleagues are afraid to speak up, hence why we're speaking up. The reality is that just yesterday I was in a facility I'm not going to mention, and one of my colleagues said, but let me not speak with you here because my boss is listening or my boss will know. The reality is that it's CEOs and CFOs that are pushing this agenda, and nurse leaders are simply responding. Many of them are simply afraid of losing their jobs, and those that are courageous, some of them lost their job, as you know from last year's release of Mind the Gap report. So it's not as simple as nurse leaders. In the ideal world, that should be the case, but we don't live in an ideal world, so thank you.
Can I just add a comment? Also, not all administrative staff who are hiring are nurse leaders. Some of them are not nurses, and they don't understand the complexity and the knowledge and skills and ability that the RN brings to the job. So to assume all leaders who are hiring are nurses, that's not true.
Yes, I had, thank you for that comment. I actually had the opportunity this past fall to travel across the province and across the system in a variety of care settings, everywhere from public health right through to acute care and long-term care. And I saw just that. I saw decisions being made by senior administrators who were not nurses, who truly did not understand the patient impact of their decision. It was absolutely financially driven. I also had the opportunity to speak to nursing leaders who some actually talked about being in a sense of moral distress, knowing that it was the wrong decision, but afraid to speak out and really feeling the fiscal pressures in the organization and not doing it for the reasons of the best interest in care of the patient.
So we will entertain other questions because the media room is needed for other people when we come out of the room. Let me say that to all of your questions, the research is now there. Nurse leaders will be able to hopefully support their decisions better, but we cannot ignore that nurse leaders also have others that are pushing them to deliver on a short-sighted strategy. We would suggest that all nurse leaders, CEOs, CFOs, and the government and opposition parties, as you build your own platforms, look at the evidence and actually do what's right for Ontarians. The evidence is robust, is overwhelming on the fact that RN care produces less mortality, less morbidity, more satisfaction, decreased length of stay, and all the other many aspects that are on your kit. And I invite you to visit the website. If you have additional research, absolutely bring it to us. It will be included. And with that, despite of the difficulty of what we share, happy Nursing Week to everybody, to our colleagues around the province and country. And let me tell you, in other countries, they're watching what we are doing as well. So it has ramifications way broader than only us here. So thank you for all of you for attending, and happy Nursing Week to you.
Thank you. Happy Nursing Week, everyone.